Well, thank you, Dr. Yan, for the very generous introduction. You're right. I have a long-standing relationship with the Blepharospasm Foundation. I was very fortunate and honored to have Mary Lou Koster, the founder of the foundation, to be my patient, and it was an honor for me to participate in her care. I remember when she first saw me, she said, it took me several years to be diagnosed. Is there anything that I can do to help other patients with blepharospasm so that they are diagnosed early and treated early? And we brainstormed for several weeks or months, and finally we decided that the best way to do that is to establish a foundation for blepharospasm research, and that's how all this got started, and I was fortunate to be the first scientific director. In fact, we were the first ones to organize this blepharospasm meeting, and this was the first Benign Essential Blepharospasm Research Foundation meeting. It was here in Houston in October of '82. At the time, I still had black hair, and I had hair. But I want to recognize Dr. Wilkins, Dr. Richard Anderson, Dr. Bayless. These individuals obviously played a very important role in the foundation and the origin of the foundation. But above all, Mary Lou Koster obviously played a key role, and I've had a long-standing relationship with her. It was clearly an honor for me to know her. And we also organized the 20th International Meeting on Blepharospasm here in Houston to celebrate the 20th anniversary. And you recognize some people, including Dr. Ando, who just spoke, Dr. Alan Scott here in the back, a number of other people who had a prominent role in the development of the Blepharospasm Foundation. Dr. Tolosa, who is one of my closest friends and colleagues from Barcelona, hosted, I think, the second Blepharospasm meeting in Barcelona. My last participation in the Blepharospasm meeting was actually in Denver about 3 years ago, and I had occasion to talk to a number of people who are obviously very much involved and play a key role. And I want to recognize Nilda Rendino and Avolmat and Mary Lou Thompson, the daughter of Mary Lou Koster, as the saints. That's why this represents a halo, because they are clearly the saints who have promoted the foundation and built on the success of the previous leaders. And now the foundation is in new hands, new leadership, and I'm very optimistic that the foundation will continue to thrive. So the topic that I was assigned to talk about is research. Some of the things that I'm going to say already were mentioned, but I'm going to highlight some areas of research that have not yet been highlighted. You have heard about the relationship between blepharospasm and dystonia. And the word dystonia, Mary Lou used to call it a D word, meaning she did not want to hear about dystonia. And those of you who remembered those discussions, she did not like the idea that we should call blepharospasm dystonia, because she wanted to make sure that blepharospasm is a separate, unique entity. And it took me about 20, 30 years to finally convince her to accept the notion that blepharospasm is a form of dystonia, and dystonia falls into the category of movement disorders, neurologic movement disorders. One of the most common misconceptions about blepharospasm is that it's an eye disorder. It's not really an eye disorder, it's a neurological disorder, even though eye abnormalities sometimes can contribute, and we had a discussion about the relationship between blepharospasm and dry eyes and blepharitis and all that. But these are sort of a secondary changes that can occur in the eye and may contribute possibly to blepharospasm. But basically, blepharospasm is a brain neurological disorder and falls into the category of movement disorders. And within movement disorders, there are many categories. There are so-called pyramidal syndromes, where most of the abnormality is in the spinal cord. There are some abnormalities in the cerebellum, which is the part of the brain that has to do with balance and coordination. But brunt of the pathology probably is in the basal ganglia. And I use the word pathology not because if you examine the brain of a patient with blepharospasm, you don't really see any abnormality in the brain, including the basal ganglia. So we think of the basal ganglia as playing an important role in a physiologic rather than pathological way, but clearly it plays an important role. So movement disorders can be divided into hypokinesias and hyperkinesia. Hypokinesia just refers to slowness and poverty of movement. Hyperkinesia means abnormal involuntary movement like tremor, chorea, tics, and dystonia, including blepharospasm. And within these categories, there are a number of other subcategories that we don't have time to discuss. But the take-home message from this slide is there are many, many movement disorders. Dystonia is one of them, and within dystonia, blepharospasm is obviously a very important form of dystonia, movement disorder. Now, there's a lot of discussion in the literature about when was first blepharospasm recognized, and there are many, many areas of research that suggest that blepharospasm has existed for thousands of years. And here are some examples how artists have depicted blepharospasm. This one is from a student of Leonardo da Vinci showing this person with blepharospasm. Most likely had blepharospasm. I doubt that the individual just closed their eyes. When I was recently in Vienna, I came across a whole collection of sculptures by Messerschmitt, including this one that clearly depicted blepharospasm. So blepharospasm has been depicted in the art for many, many decades or centuries. Here's one of the more famous paintings by the Flemish artist Bruegel, who painted this woman who presumably had blepharospasm and jaw opening. You know, she could be just yawning, for all we know, but we suspect that she might have blepharospasm and jaw opening dystonia. And the reason why I show this picture is because this picture was used in the original description by David Marsden that Dr. Arno mentioned. He's one of the leaders in the field. And he was the first one to suggest that blepharospasm is a form of adult onset focal dystonia. So he was the first one to link this blepharospasm with the whole field of movement disorders called dystonia. But the person who actually first described blepharospasm was Horatio Wood, who was a physician at the University of Pennsylvania, who in 1887 described conditions such as facial convulsions that he referred to that caused spasm of the orbicularis palpebrum or orbicularis oculi that we now refer to. And he was the first one to actually use the term blepharospasm. And he really eloquently described the clinical features of blepharospasm. So that was in 1887, a long time before Mage. Now, you heard the term Mage before, and I always have trouble with that term for a number of reasons. So Henry Mage was a French neurologist who in 1910 described a series of patients, all women, who had spasm of the face, including eyelids and jaw and tongue. And for some reason, that publication in 1910 got a lot of attention subsequently, and people started to refer to this condition of facial spasm, including blepharospasm, as Mage syndrome. There are many reasons why Mage should not be giving that credit, and I can give you a whole hour lecture just on that topic alone, but I'm going to spare you that. One reason that I just listed is that he was not the first one to describe it. I mean, 23 years earlier, Horatio Wood was the one who first described it, so why should Mage get the credit? And there were many other reasons why I don't think Henry Mage should get the credit. I'll be happy to talk to you privately about those reasons. So don't get me started. So that is one of the reasons why I prefer the term cranial-cervical dystonia, which may not sound as easy to pronounce as Mage syndrome, but it's a much more appropriate term because it describes the condition as dystonia involving cranial, meaning facial, neck, cervical structure. So cranial-cervical dystonia is the appropriate term for patients who have blepharospasm and often other facial spasms, including neck spasms, cervical spasm. So blepharospasm is dystonia. Dystonia is a neurological disorder dominated by involuntary, sustained, spasmodic, repetitive, and pattern. Dr. Ando emphasized the term pattern. The word pattern means that the same group of muscles are always involved. So you don't have somebody with, let's say, blepharospasm having, spasm of one side of the face, and then next time the other side of the face, and next time, jaw involvement. It's always the same group of muscles that's involved. So that's what we mean by pattern. And it can cause twisting, squeezing, like blepharospasm and other abnormal movements. It's a form of focal dystonia. It's often wrongly referred to as benign essential blepharospasm, which is the name of this foundation, right? So I even have trouble with that particular term, and I have many, many discussions with Mary-Lou Koster. I didn't want to call it benign essential blepharospasm foundation. First of all, how many of you think blepharospasm is benign? Not a single hand, okay? How many of you think it's essential? You can live without it, right? So it's not essential. Nevertheless, I lost the battle with Mary-Lou, and as I have lost many battles with her. And the foundation is called the Benign Essential Blepharospasm Research Foundation. That's probably not going to change, and we just have to live with it. But hopefully you will stop using the term Mage syndrome for a number of reasons. Bruegel syndrome, based on that depiction of that woman who might be yawning, is another wrong term. So again, I urge you to use the term blepharospasm alone and recognize that blepharospasm is a form of cranial-cervical dystonia. Now, since the establishment of the Blepharospasm Foundation, or even before then, there has been growing interest among physicians and scientists in this condition, and this is reflected in a number of publications that have increased at an exponential rate, as noted in this diagram. Now, how common is blepharospasm? There have been a number of epidemiological studies, but this particular paper by Steves, published in 2012, I think is the best review of the epidemiological studies in blepharospasm and dystonia. And they found that the overall prevalence of dystonia is about 16.4 people per 100,000. Of these, cervical dystonia, neck dystonia is the most common, accounting for about 5 per 100,000, and blepharospasm, the second most common, accounting for about 4.2 per 100,000. So that is the best data we have on the epidemiology of blepharospasm. So it is a relatively uncommon condition, but unfortunately frequently misdiagnosed or undiagnosed. Now, if you want to learn everything there is to know and more about dystonia, I suggest you might want to pull up this article. I gave you the reference here. I was honored to participate in this review. And it talks about just about everything you always wanted to know about dystonia and blepharospasm. We also talk in that review article about how we classify dystonia, and this new classification is based on this paper that took us about 8 years to write, to derive a consensus of how we're going to classify dystonia, especially blepharospasm. So we define dystonia as a neurologic movement disorder, repetitive movements. We already talked about the term pattern. Some patients don't have twisting type movements, but have contraction of certain muscles, like in case of blepharospasm, the orbicularis oculi muscle predominates. In the case of larynx, for example, the vocal cords can contract, and patients have what we call spasmodic dysphonia, where they have a very strained voice, or they have a whispering voice, and that's often associated with blepharospasm. So not every patient has a twisting movement, as most patients with dystonia have. Some patients have a contraction of these individual focal muscles. So we classify dystonia into clinical characteristics such as age at onset, body distribution, temporal pattern, associated features, and then etiology. What is the cause of the dystonia? And hundreds and hundreds of different causes that we'll talk about in a moment. We are not going to talk about all the hundreds of causes. So it usually starts with frequent blinking, intermittent spasms of the eyelid muscles. Blepharospasm is considered a bilateral condition, meaning both eyes are involved, but it's often asymmetric. I would say half, maybe even more than half of my patients have involvement of one eye more than the other, and as we use botulinum toxin to treat it, we often have to adjust the dosage accordingly. So it involves different muscles of the eyes that we're going to talk about in a moment. Many patients have associated spasm of the face, the jaw, tongue, and neck, and we talked about larynx in cases of spasmodic dysphonia. It is often painful. It's not just because of the photophobia, but the actual contraction can be painful. That's something that is not often recognized by physicians. And although the visual acuity is preserved, because we told you this is not an ocular problem, this is a neurological problem, because of the involuntary eyelid closure, patients have difficulties performing activities of daily living, reading, watching TV, and so on. So it can cause sort of a functional blindness, even though it's not due to poor visual acuity. It is often triggered by bright light and when a movement, and this morning driving east on 610 with a bright light, bright sun coming at me, I really was thinking, boy, what would it be like if I had blepharospasm? I had trouble driving without blepharospasm, but if I had blepharospasm, I'm sure I would have to pull over and would not be able to drive. So it often gets better when patients concentrate or when they look down, but it's worse at rest and while looking up. And it's often said that patients with blepharospasm, they notice that when they talk, the blepharospasm gets better, and that's why a lot of patients with blepharospasm talk a lot. And they are wonderful dinner guests because you can just sort of sit back, let them talk, and that's wonderful. Many of them found variety of alleviating maneuvers, so like pulling on the upper eyelid, touching the forehead or eyebrow, pinching the neck, humming, coughing, yawning, talking, and singing. If I had time, I would show you a video of one of my patients. She has very severe blepharospasm, but when she starts singing, the blepharospasm completely resolves. The progression can vary over a period of days, weeks, or months, and sometimes it takes several years to fully evolve. There are some patients, maybe up to 12% of patients, that undergo spontaneous remission, meaning the blepharospasm gets better on its own. That's uncommon, and even when it does occur, it's almost always transient. So unfortunately, all these patients that have the spontaneous remissions, almost all of them have a recurrence of their blepharospasm, so it's pretty much a permanent condition. It's often misdiagnosed and attributed to a variety of psychological factors. It's often misdiagnosed as hysterical, conversion reaction, psychogenic, or functional, and it's not. Although there may be some associated depression or psychiatric type symptoms, this is not a psychiatric condition. It must be differentiated from other conditions, and was already mentioned by previous speakers, like ptosis, which is due to weakening of the eyelid. Apraxia of eyelid opening was mentioned. So again, apraxia of eyelid opening is a condition that may resemble blepharospasm, but it's a different condition. So instead of patients having involuntary closure of their eyes, patients with apraxia of eyelid opening have trouble opening their eyes. So if you ask them to close their eyes, they cannot open their eyes. Now, there are many patients, particularly those patients that have Parkinsonian type conditions, that have both. They have blepharospasm that triggers the apraxia of eyelid opening. So the blepharospasm actually causes the closure of their eyes, and then they are unable to open their eyes because of the apraxia of eyelid opening. It's a complicated condition, but it's something we are very interested in trying to understand the mechanism of that. So there are many alleviating maneuvers trying to open the eye by opening one eye and closing the other eye, touching on the eyebrow using the variety of tinted lenses. I think you are all familiar with it. Here's an example of a patient that has classic cranial-cervical dystonia, blepharospasm, oromandibular dystonia, meaning dystonia of the jaw and mouth, and neck or cervical dystonia. So we talked about blepharospasm, oromandibular dystonia. We talked a little bit about spasmodic dysphonia, the laryngeal dystonia, where the patients have strained voice, cervical dystonia. But one thing we have not mentioned yet is the relationship between these dystonias, these focal dystonias, and tremor. That is, again, something I've been very, very interested in, because we found about 25% of the patients with blepharospasm, or maybe even more, have tremor in their hands. So if you ask them to downstairs their hands, they have tremor in their hands. So, and that is sometimes referred to as essential tremor. Again, wrong term. There's nothing essential about this tremor, but that's the term that is being used, and it's a genetic condition. What the relationship is between essential tremor and dystonia is not absolutely clear yet. So what the heck is dystonia? I wish I could tell you. I really don't know what dystonia is, but I can share with you some thoughts about dystonia. So we know that there are many conditions that involve certain parts of the brain, especially the basal ganglia, that may be associated with dystonia. So we know that the basal ganglia play an important role in dystonia. I'm not going to bore you with all the details of the anatomy of the basal ganglia, but it just shows the basal ganglia, and there are different parts of the basal ganglia. And you've heard from previous speakers talking about the GPI, for example, which is one of the targets that's used for DBS. So as a result of the physiological abnormality in the basal ganglia and its connections with the cerebellum and the cortex, the facial muscles go into spasm, and it can involve the orbicular oculi, as in blepharospasm. And there are three parts of the orbicular oculi: the orbital, preceptal, and the pretarsal portion of the eye muscle. There's another muscle that is important, and that's the levator muscle, which elevates the eyelid. And it's this is the muscle that we are most worried about when we inject botulinum toxin. That's the reason why we keep the botulinum toxin away from this muscle, so inject laterally and medially, hoping that the botulinum toxin is not going to diffuse into this levator muscle, because weakening of the levator muscle can cause ptosis or droopiness of the eyelid. And then Dr. Ando talked about aproclonidine, which is a drug that we discovered might be helpful in some patients with blepharospasm, which acts on a totally different muscle, mainly this tarsal muscle of Mueller, which is innervated by different mechanism than the other muscles. So there are a number of muscles that are involved in the closure and opening of the eyelids. We need to understand the anatomy and the physiology of these muscles. We already talked about the importance of blink reflex, and there is a mounting body of evidence to suggest that in blepharospasm, this blink reflex is abnormal. There is hyperactivity of this blink reflex, and that is one of the pathophysiologic mechanisms of blepharospasm. And there is increased sensitivity of the eye to sensory stimuli such as light touch, wind, light, that can trigger blepharospasm because of the hyperactivity of this blink reflex. So there are many studies that have looked at the blink reflex, and essentially all of them have confirmed that the blink reflex in blepharospasm is abnormal and may lead to photophobia, the sensitivity to light, and involuntary eye closure as a result of exposure to light. There are different parts of the orbicularis oculi that are involved in the blink reflex, and especially the orbicularis oculi, and that's the one that is most involved with blepharospasm. There's co-contraction of the orbicularis oculi, which closes the eye, and the levator muscle that I just mentioned that tries to open the eyes. And that's the fundamental nature of dystonia. There's co-contraction of opposing muscles, in this case, orbicularis oculi and the levator muscle. The blink reflex is hyperexcitable, and there is some evidence that there is a loss of inhibition of this blink reflex in blepharospasm. I gave you some references here. If you are really interested, you can do a PubMed search on this. The cytopathology in blepharospasm is really not known. If you do MRI scan, as it has been done in over 1,000 patients in this study, only 1.6% of those MRI scans are abnormal. So 99% of MRI scans of patients with blepharospasm are essentially normal. There are some functional MRI type studies. It's a specific type neuroimaging study that looked at metabolism of different parts of the brain. And again, no consistent findings have been found. And there's some evidence that dopamine might be decreased, particularly in the basal ganglia patients with blepharospasm. We published some data on that. If you do a DBS, deep brain stimulation, and you record from the globus pallidum internus that we talked about earlier, you find that there is actually increased firing rates in this particular part of the basal ganglia. So the GPI that you heard about probably plays an important role in generation of blepharospasm. Blepharospasm can be seen in different conditions, including a variety of Parkinsonian conditions, including Parkinson's disease, but other Parkinsonian conditions like progressive supranuclear palsy. And that alone tells us that the dopamine system probably plays an important role in blepharospasm. We reported long time ago patients who had structural lesions in the brain and developed blepharospasm. So they had either stroke or multiple sclerosis or some other neurologic lesion, and then developed blepharospasm. And the point of that article was that certain parts of the brain, including the part called brainstem and basal ganglia, clearly play an important role in blepharospasm. So the brainstem and what we refer to as diencephalic structures or basal ganglia play a role. Also, there are many examples of other structural lesions that can cause blepharospasm. Now, I don't expect you to read this slide. The only point I want to make from this slide is that currently there have been many genes identified as cause of blepharospasm. And here I show a list of what we refer to as isolated dystonias, meaning there's nothing but dystonia. So these patients have pure dystonia, no other neurologic abnormality. And you can see that there's essentially a dozen of genes that have been identified in a mutation in which can cause dystonia. And here you can see that a lot of these conditions also have cranial-cervical dystonia, meaning blepharospasm is involved. So these are genetic conditions that can cause blepharospasm. And then there are combined dystonias, meaning dystonias that are associated with other neurologic problems like Parkinsonism or other movement disorders. And again, many of these conditions can cause cranial dystonia, including blepharospasm. Now, I think all of us recognize that genetics does play an important role, and we had a discussion during the panel about what percentage of patients have family history. A lot of it depends, how you ask the question. But in my experience, maybe 20% of patients with blepharospasm have other family members with blepharospasm or dystonia. And if you extend it beyond dystonia, including the essential tremor that I mentioned before, the percentage may be even higher. So there have been a few studies that have used very sophisticated genetic techniques to see if there are any specific genes that can be linked to blepharospasm. This particular study used what's called whole exome sequencing, which is a very sophisticated genetic technique, and they could not find any specific gene associated with blepharospasm, despite all these families that are listed here, where some members of the family had blepharospasm. The most recent study just published from NIH used a slightly different technique where they looked at specific genes, and again, they could not find any specific gene. There was one gene called REAP4 that may have been linked to blepharospasm. The only important observation from that finding is that this protein that is made by this gene is involved in what's called endoplasmic reticulum, which is a part of the cell that we know is involved in the most common genetic form of dystonia called DYT1 dystonia, which is the most common form of genetic dystonia. So this observation obviously needs to be extended to see whether there's anything specific about this particular gene. So just sort of to summarize, we think that blepharospasm probably arises from underlying genetic susceptibility, and even though we don't have any genes yet that have been clearly linked to blepharospasm, we think that even in sporadic blepharospasm, when there is no family history, genetic factors probably play an important role. The genetic susceptibility can lead to abnormalities in the basal ganglia, such as decreased dopamine, decreased dopamine receptors. There's loss of inhibition, particularly in the blink reflex that I mentioned, and there are a variety of sort of psychological or sensory abnormalities that can be associated with blepharospasm and may precede the onset of blepharospasm before the actual motor manifestation, meaning the actual blepharospasm occurs. So there are many areas of research that we are going to have to think about in the future, including studying the connectivity between the different parts of the brain and whether patients with blepharospasm have a specific pattern of connectivity between the basal ganglia, cerebellum, and cortex. We would like to also know the relationship between the ocular disorders and ocular trauma or damage and blepharospasm. So even though I just told you that blepharospasm is not an ocular disorder, it turns out that certain ocular disorders, including dry eyes, but even injury to the eye, can actually trigger blepharospasm, and this is an interesting observation that I'm particularly interested in, finding what is the mechanism of that. We need further genetic studies because genetics, I think, plays a very important role in the causation of blepharospasm. And we need better medical treatment, even though botulinum toxin treatment is considered to be the treatment of choice. There are many disadvantages of botulinum toxin. It's not an ideal treatment. It has to be repeated. Some patients have complications. And we are looking at new forms of botulinum toxin that might have some advantages over the three currently available formulations of botulinum toxin. And then we obviously need better surgical and non-surgical treatments. If you are interested in botulinum toxin, you are invited to our next International Congress on botulinum toxin in Sweden. We're going to talk about a variety of new formulations of botulinum toxin that are still in development and still considered experimental, but eventually hopefully be on the market. So I'm going to stop here and thank you for your attention.
Mike on. I thought we'd just have, and Dr. Jankovic agreed to have the question and answer for his talk, perhaps right now.
I think you're going to have a presentation this afternoon on botulinum toxin, right? So hopefully the speaker will talk about some new developments in botulinum toxin. But we are testing a couple new formulations of botulinum toxin. Again, these are all experimental in order for you to be involved in that clinical trial. You have to have a certain form of dystonia. Right now, we are not testing in blepharospasm. We are testing in cervical dystonia. But these formulations of botulinum toxin promise to be perhaps a little bit more effective, longer lasting. They hopefully don't diffuse into adjacent muscles, the unwanted muscles. So there are some, potential advantages of these new botulinum toxin. But maybe the speaker this afternoon can address that.
Okay.
Yes.
I have a question. You mentioned you had an article that linked multiple sclerosis and blepharospasm. You mentioned that you're the first person I've heard that. I've had MS 32 years. I've had blepharospasm 7, and I've had trigeminal neuralgia 4. One of the other speakers mentioned the 7th nerve for blepharospasm. Well, that's a trinerve, and TN is the 5th nerve. So what is the link? And I would like to read that article. Can you give us how we would get a hold of it?
Well, let's see. I suppose I can send it to the Blepharospasm Foundation. They can post it on the website. That might be the easiest way. That way everybody can access it. But the point of that article, again, was that there are specific conditions or lesions in the brain that can cause blepharospasm, including, multiple sclerosis. And as you probably know, multiple sclerosis can also cause trigeminal neuralgia, which involves mainly the 5th cranial nerve, as opposed to blepharospasm, which includes mainly the 7th cranial nerve. But there is probably a relationship between multiple sclerosis and some cases of blepharospasm. It doesn't mean that patients with blepharospasm should be tested for multiple sclerosis, but if they have features of multiple sclerosis clinically or on MRI scan, then that link may be relevant. Right. MS can cause lesion, particularly in the brainstem, which we think may be relevant to blepharospasm.
Dr. Jankovic, this is a question from the audience as well. Any indications that blepharospasm is a harbinger for Parkinson's?
So blepharospasm itself is not necessarily a risk factor for Parkinson, but turning it around, patients who have Parkinson's disease are more likely to have blepharospasm.
Right.
So I don't think there's any concern that if you have blepharospasm that you're going to develop Parkinson. Although there is this link that I mentioned between blepharospasm and essential tremor, and there are some patients with essential tremor that eventually do develop Parkinson. But the link between blepharospasm and Parkinson is very weak.
Hi, I've got my twin sister here. We're identical. I have all the symptoms and more. She has none. Wondered whether if there have been any sort of twin studies done. Last conference I was at, there had not been any real information. I think that they had stated something related to the late onset age diagnosis, and that there was difficulty in performing long-term studies in that regard, and I wondered whether or not there was any thing new on that in that department. You
mean in the study for twins?
For twins.
Yeah. Right. So there have been many conditions studied in twins, like for example Parkinson's disease, but to my knowledge, I don't think there have been any twin studies in blepharospasm, but it's a very important study to do. And I do have at least 2 or 3 twin siblings in my practice that have blepharospasm. So again, it underscores the importance of genetics, but this has not led to a study that would eventually identify the gene.
Okay, I have one question, and I would say Dr. Jankovic is a great doctor because he is my doctor, and I appreciate it. But one question I have, with the Botox or botulism treatment, is there a time that it becomes less effective over, and I'm talking about over years, 2, 3, 4 years? Does it I mean, right now it's working.
I mean, I've been doing botulinum toxin treatment longer than anyone. We were fortunate to be the recipients of the first Blepharospasm Research Foundation grant that led to the initial double-blind control study that we did at Baylor, which led to the approval of botulinum toxin. So we've been doing botulinum toxin longer than anyone. And I frankly don't recall any patients that I would say lose the benefit from botulinum toxin. Now, having said that, there is some concern with some patients, particularly if they use the old Botox, that they could develop antibodies or resistance, and that certainly can cause loss of efficacy. But generally, we don't think that patients lose their benefit from botulinum toxin. They may need higher dosages as the time progresses because the condition may be getting worse, but unless there is immunoresistance, in other words, formation of neutralizing antibodies, the patient should not lose efficacy from botulinum toxin.
And probably really important to point out that those studies that showed antigenicity, those formulations are no longer available. The formulations have been reformulated to reduce the protein load in each of the formulations, regardless if you're talking about Botox, Dysport, or Xeomin.
Right. So
I mean, it's not really comparable.
I agree, but I want to add on to this. So there has been a recent resurgence of interest in antigenicity and antibodies in botulinum toxin, and we have a paper that just got published on immunogenicity. And one of the reasons why people are now concerned again a little bit about antigenicity because some of the formulations, including Dysport, which I rarely ever use, but Dysport has been increasingly associated with the formation of antibodies, and myoblock, which is another one, the type B botulinum toxin, can be associated with antibodies. So in most cases, you don't need to worry about it. It does not cause resistance. But your physician who administers botulinum toxin needs to be aware of that possibility that you could potentially develop antibodies. This is more commonly seen in patients who require injections not only for the eyes but also for the neck and for other forms of dystonia. So if they have, if they require high dosages of botulinum toxin, spasticity patients. Yeah.
Well, I think we need to move on to the next talks. I want to thank Dr. Jankovic again. We would not be here today, where we are today, without Dr. Jankovic's commitment. Thank you.